البدايه برحب بكل الحضور ويشرفني ان يكون يرأس الجلسه استاذ الدكتور مجاهد ابو المجد واستاذ الدكتور مصباح two of the iconic figure for all endocrinologists and diabetology. هنتكلم النهارده عن evidence based choices on path to insulin initiation في عيان type 2 diabetes. Actually هنبدا في البدايه ب first case. عندنا احمد ده عيان بيجي لحضراتكم في clinical practice. ده 40 years old male patient known to be diabetic من حوالي 9 سنين. العيان also hypertensive, smoker and dyslipidemic, has multiple risk factors with a family history of heart disease. He came to your clinic as usual for a regular follow-up, but he was upset because of the uncontrolling of his blood sugar. Also, he has a severe manifestation of the hyperglycemia in form of polyuria, polydipsia, with significant weight loss over the last 2 weeks. His previous A1C 8, and now the A1C is 9.5, in spite of being focused on the plan of surgery, on the plan of treatment over the last 6 months. He's accountant, smoker, regular lifestyle. Actually, he experienced before GLP-1 agonist, but discontinued because of the GIT upset. By examination, blood pressure is quite controlled. BMI is 27%. Head and neck, chest and heart and abdomen examination, lower extremities reveal nothing and clinically free. Neurological examination show evidence of mild neuropathy detected by the monofilament test. And we asked the patient for a lab like lipid profile showing dyslipidemia, albumin creatinine ratio at 25% with estimated GFR is 60. طلبنا من احمد يعمل لنا SMG او 6 point reading. لقينا actually عنده الهايبرغلايسيميا mainly fasting hyperglycemia with mild postprandial hyperglycemia. So, what is the option for management of Mr. Ahmed? هل انا هزود الاورال؟ اكشولي احمد كان ماشي على SGL2 metformin وسلفونيليوريا. هل انا اعمل addition of another oral anti-diabetic drug ولا initiation basal with prandial insulin and stopping of the all oral anti-diabetic drug ولا initiating basal with stopping of the all oral anti-diabetic drug or initiation basal and continue the oral anti-diabetic drug؟ رأي حضراتكم ايه؟ هل انا ادي العيان فرصه تاني للاورال؟ ما اعتقدش ان احنا عيان مر عليه 9 سنين وجاي بسيفير مانيفستيشن هنديله فرصه للاورال. اكشولي هنبدا المفروض بانسولين ثيرابي. طيب هبدا بانسولين ثيرابي with prandial at the same time. One of the main rule in initiation of the insulin therapy start simple and safe. يعني نبدا mainly بالبازل as a rule to fix fasting first. So the option here is starting the basal insulin with continuation of the oral anti-diabetic drug, especially SGL2 has a cardioprotective effect. وده اللي أكدته الجايدلاينز when to initiate the insulin therapy and management of type 2 diabetes. Many of the patients with type 2 diabetes after 5 to 10 year failure of the oral anti-diabetic drug and need to initiate injectable therapy like insulin therapy. But the patient with a severe manifestation of the hyperglycemia or acute insult or preoperative, you should initiate the insulin therapy with maintaining of the oral anti-diabetic drug that having cardioprotective effect like SGL2. ال ADA guidelines in 2023 أكدت على الموضوع ده وقالت إن إحنا المفروض after failure of the oral anti-diabetic drug we should start basal insulin with a dose 0.1, 0.2, and also the American Association of the Clinical Endocrinology قالت لنا total daily dose in the if you start insulin if the patient A1C is more than 8 you will start 0.2, 0.3 unit per kg. So not forget the 3 rule on initiation of the insulin therapy. Keep it simple and safe, fix fasting first, and avoid insulin pitfall and over-visualization. So the dose of the insulin, 0.1, 0.2, every increasing and not reaching your target, you will increase titrated dose by increasing 2 units above your target by 20 milligram every 3 days to 5 days. To reach your target, the A1C, according to the ADA guidelines, individualize it according to different factors. And the pre-prandial should be from 80 to 130, and post-prandial should be less than 180. And also time range should be more than 70, below the range less than 5, and above the range less than 25. طب ايه important انا احاول اقلل من ال A1C؟ The impact of reduction of the A1C actually بيقلل according to UKBDS ان انه بيقلل عندي من كل المايكرو and macrovascular complication. Even the reduction of 1% of the A1C, reducing the microvascular complication by 37% and amputation by 43%, deaths from the diabetes by 21% and 40% of the heart attack and 12 from the stroke. اللي بنسميها 3-point MACE. And don't miss the mistake of over-visualization. لما اقول over-visualization يعني انت معنى كده ان basal insulin above 0.5 unit per kg, you must take care that when initiating the insulin therapy, you must show that basal insulin not more than 0.0 unit per kg per day, with a postprandial insulin still not controlling 180 milligram per deciliter, and still you're not reaching your target of the A1C, with a difference between the bedtime and the AM is more than 50 milligram per deciliter. وده اللي أكدته ال ADA guidelines 2023 in intensification important of the intensification therapy. Either زي ما دكتور أحمد قال ممكن ندي fixed combination therapy with GLP-1 or addition of the prandial insulin at the time of the main meal. Even the American Association of the Clinical Endocrinology أكدت الموضوع ده by importance of intensification therapy for the patient and avoiding the over-visualization. What the hazards for delaying of the intensification therapy? One of the main hazards is increasing the risk of the cardiovascular disease. Even the patient that having a constant A1C more than 7 without intensification therapy for 1 year, a patient هيدخل في incident of 3-point MACE from MI or stroke or even cardiovascular disease. What are the barrier against؟ وده المشكلة اللي بيحكي عليها أغلب الفيزيشن. إيه البارير؟ ليه أنا بخاف أدي العيان insulin therapy؟ Actually, from my side as a healthcare provider, from the patient side, and from both of us, we fear from the hypoglycemia because instance of the hypoglycemia in the patient make him not adherent, discontinue the therapy. طيب from the patient بيحس إن ده failure, personal failure. في نفس الوقت الخوف من الانجكشن, fear from the injection, fear from the adherence, lack of support and lack of resource, and not have the courage for titration. From my side, it is a part of the clinical inertia, and don't be a part of clinical inertia. So you should avoid the insulin pitfalls. One of the insulin pitfalls, you describe insulin without following your patient. You must follow your patient because many of the patients after initiation of the insulin therapy fail to reach the A1C. So titration is important. وعشان نكون واخدين بالنا ان الانسولين لما بنعمل initiation of the insulin therapy, we have a two period of initiation and titration, which usually take from 8 to 12 weeks, or maintenance, which have the stable dose except if the patient enter in the instance of the hypoglycemia. One of the main disadvantages during the titration is incident of the hypoglycemia, which may occur with the first generation basal insulin. So, incident of the hypoglycemia in a period of titration sometimes may occur also in maintenance periods. So, what are the options for the basal insulin? ايه الاوبشن اللي قدامنا؟ The basal insulin should have the balance between reduction of the A1C and decreasing the incidence of the hypoglycemia with more flexibility. What are the options for the basal insulin? We have multiple options for long-acting insulin. But here, one of the spectacular study is the BRIGHT study, who actually عملت comparison between the glargine 300 Toujeo and degludec 100. In a previous naive type 2 diabetic patients not controlling the oral anti-diabetic drug plus or minus GLP-1, خدوا two group وشافوا ال end result in reduction of the A1C. Actually, there is non-inferiority of the glargine 300 versus IDEG 100 in reduction at the end of the study. Also, the incidence of the hypoglycemia is less with the glargine 300, and also the incidence of the nocturnal hypoglycemia, which occur from midnight to 6 a.m., is less with the glargine 300. What about a special population like renal impairment? Actually, glargine 300 showing a reduction of the A1C more safe with less incidence of the hypoglycemia, and also even in geriatric and elderly patients. What is the difference between glargine 100 and glargine 300? Actually, it's smaller in volume and smaller depot sub-Q, and also more stable pharmacokinetic and pharmacodynamic with more prolonged action. Toujeo glargine 300, what about the incidence of the hospitalization because of the hypoglycemia? Actually, when comparing Toujeo glargine 300 with other first generation basal insulin like glargine 100, it is lower in the incidence of hospitalization because of hypoglycemia. So our conclusion and take-home message, glargine 300 Toujeo in a comparison with glargine 100 is a stable prolonged glucose lowering effect, lower incidence of the hypoglycemia, more flexible and lower weight gain. Also, glargine 300 in a comparison with IDIB 100, it is similar in glycemic control with lesser of the hypoglycemia, with a favor of less instance of the hypoglycemia, especially with the glargine 300 during titration period. And finally, the BRIGHT study sub-analysis in a special population, like a patient that having renal impairment and elderly, showing a significant reduction of the A1C with lower instance of the hypoglycemia, and thank you.